Congratulations on deciding to take this important step on managing your weight. All of us at Anchorage Bariatrics look forward to following you along this path and sharing in your success. The purpose of today's visit is to review some of the details about surgery so that you can make an informed consent. Specifically, we're going to talk about the nature of the procedure, the risks and complications, the benefits of surgery, the alternatives to surgery, and your expected recovery.
You have chosen the sleeve gastrectomy surgery. This is an excellent choice for your weight loss goals. The first form we will review is the hospital consent form. You should have a copy of it next to you to refer to if needed. The sleeve gastrectomy is performed using minimally invasive laparoscopic surgery. 5 small incisions are made, all less than about 1 inch long. The stomach is stapled and about 85% of the stomach is removed. You are left with a stomach about the size and shape of a small banana. The procedure is performed laparoscopically, but there is always a chance of requiring a larger open incision. I also perform an upper endoscopy to check the stomach for any leakage. In addition, if required by your anatomy, I may perform a liver biopsy and/or a hiatal hernia repair, which is a hernia of your stomach above your diaphragm muscle. The benefits of surgery are why most people choose to do the surgery. As you can see from this graphic from the American Society of Metabolic and Bariatric Surgery, we can make significant improvements in major and minor medical conditions related to your weight. Other benefits include decreased cancer risk, specifically from colon and breast cancer, improved outcomes from non-bariatric operations like hernia repairs or joint replacements, and an improved quality of life in 95% of people. This is an elective surgery. The alternatives to surgery include continued diet and exercise therapy or medication-assisted weight loss. The only downside to these options is that we've tried them before without lasting success. Now let me tell you a little bit about your expected post-op recovery. You will spend 1 night in the hospital and will be discharged once you are hydrating well. Most people can return to a non-strenuous job in about 10 to 14 days. I request you walk frequently throughout the day after surgery. You will also be on a liquid diet for 3 weeks after surgery. But don't worry, you will be provided with detailed instructions after surgery to answer all of your questions. Now we're going to examine in detail the potential risks and complications of surgery. This is not meant to scare you, but rather inform you of the risks. Luckily, most people have no major complications with surgery and do fantastic. However, sometimes complications do occur. But I promise you that all of us at Anchorage Bariatrics will do our very best to lower your risks, and if you do experience complications, we will deal with them to the best of our ability. You should have a copy of this form next to you to refer to if needed. The risk of reoperation and readmission to the hospital is less than 5% and is more common for complex procedures and for those patients with major medical problems. The risk of death from the procedure is only 0.28%. This is about 2 to 3 people out of 1,000. Risk factors include older individuals at greater than 65 years old, male patients, and having major medical problems before the operation. Leakage from the staple line. During the procedure, the stomach is stapled and a large portion is removed. If the staples do not fire correctly or do not hold well, the stomach could leak. Luckily, the chance of this is low at less than 1.4%, but could be as high as 6.5% for redo or revision procedures. I also perform a leak test at the time of surgery with a camera into the new stomach to ensure that you have no leak when you leave the operating room. Blood clot formation in your legs, which could go to your lungs. The risks of this happening are between 0.4% and 2.4%. Risk factors include a history of blood clots, impaired ability to walk, severe obstructive sleep apnea, and a body mass index greater than 60. Preventing this complication is crucial. I will place you on a blood thinner injection even before your operation, and after surgery, you will be encouraged to walk frequently, even the same day as your surgery. Bleeding during and after surgery. This occurs in 0.8 to 4.4% of patients. Bleeding can occur inside the intestines as well as outside. I typically use a staple line reinforcing material that decreases bleeding. The chance of reoperation for bleeding or requiring a blood transfusion is less than 1%. Infection of your incisions can occur, but again, this is infrequent at less than 5%. You will receive an antibiotic prior to surgery to help prevent this. Conversion to an open procedure. What this means is that I am unable to complete the surgery with minimally invasive techniques, and I need to make a large incision down the middle. This is very rare, at less than 1.7%. This can occur if there are complications during surgery or if the surgery is especially difficult for some reason. However, I will do whatever is the safest thing for you while you are on the operating room table. Heart attack or stroke. The chance of this happening is less than 1% and is usually a result of your heart not being able to handle the stress of the surgery. If required, we will do a full heart workup prior to surgery if I think it is needed. Pneumonia or pulmonary complications can occur up to 4.5% of the time. To help prevent this complication, it is critical to walk frequently after surgery and do your deep breathing exercises with an incentive spirometer, which we will give you after the surgery. Nerve damage. This is a very rare complication that usually is the result of positioning on the operating room table. Myself and my staff take great care to position you and pad you for surgery ourselves to help prevent this. Skin sores or ulcers. This is also a result of positioning or from prolonged surgery or a prolonged hospital stay. Getting out of bed and walking after surgery is crucial to prevent this. Injury to surrounding organs. During your operation, we will see and move multiple other organs, including your liver, spleen, pancreas, and colon. Every effort is taken to prevent injuring these organs during your procedure. The chance is less than 1%. Stomach ulcer or stricture. Ulcers in the stomach are very rare. Risks are highest in patients who take NSAIDs like Advil or ibuprofen, who smoke, who have uncontrolled diabetes, or who are on steroids. It's crucial to follow our recommendations after surgery and take the acid pill we prescribe for 1 year. A stricture or narrowing occurs in 1 to 4% of patients. This can usually be treated with endoscopy, which is a camera into your stomach, and dilating the narrow part with a balloon. However, if this is not successful, you may need another operation and possibly a conversion to a gastric bypass. Acid reflux. Heartburn or reflux is very common after the sleeve gastrectomy. It occurs in 20 to 30% of patients. We will prescribe an acid pill for you after surgery to take for 1 year. Some people will need to be on it longer. Very rarely, the sleeve needs to be converted to a gastric bypass due to intractable reflux symptoms. Development of gallstones. Gallstones are actually pretty common after gastric bypass surgery. About 30 to 40% of patients will develop gallstones as a result of the rapid weight loss. However, only 10% of patients will actually need their gallbladder removed because of symptoms. It was common for surgeons in the past to remove the gallbladder at the same time as the gastric bypass. But this practice has fallen out of favor because 90% of patients don't really need it out. In addition, it adds extra time to the surgery, which means more anesthesia and more time on the table, which can increase your chance of other complications. Bowel obstruction. Your chance of bowel obstruction from scar tissue after surgery is very rare. Hernia at the incision sites. Because we perform the procedure with a minimally invasive laparoscopic technique, hernias at the incisions are very rare. Worsening depression. This can sometimes happen after surgery, and no one really knows why. It's usually temporary. I feel that it is due to the stress of surgery and significant change in your eating habits. Many people use food as a coping mechanism, and after surgery, you can no longer use food to cope. There can be a difficult adjustment period after surgery until you find a new way to handle stress. My suggestion is to make exercise an outlet for stress and also to use our support groups, as no one understands what you're going through better than someone who has done it themselves. Prolonged nausea and vomiting. You will have occasional nausea and vomiting after surgery. It usually improves within days to weeks of surgery, but may happen intermittently into the future. Chronic nausea and vomiting is very rare. Because you have a much smaller stomach, it will affect how your vitamins and minerals are absorbed. Nutritional deficiencies are common after surgery. Over 50% of patients will have some deficiency. It's very important that you take a good multivitamin every day for the rest of your life. You will receive detailed instructions on this in another packet, and we will make sure to check these levels routinely after surgery. For your convenience, vitamin and mineral supplements are available in our clinic or through our website. Less than desired weight loss. It is very rare to lose too much weight after surgery, and this is usually due to other complications. Not losing as much weight as you expect is more common. You need to have realistic expectations. Remember, your weight is just a number, and I would encourage you not to get too stuck on a number. More importantly, my goals are to improve your overall quality of life, improve or eliminate your medical problems associated with being overweight, and to change your metabolism from a fat-storing metabolism to a fat-burning metabolism to reset your set point. My best suggestions are to follow our instructions carefully after surgery, attend the support groups, and to make exercise a daily routine. Also, remember to stay focused on yourself. It's okay to be selfish. Don't let life sidetrack you during the crucial first year after surgery. Weight regain after surgery. Most people will lose weight for about 12 to 18 months after surgery. When you reach your low point, most people will then gain about 5 to 10 pounds before leveling off for the long term. However, about 15% of patients will regain most or all of their weight after surgery. There are a few rare conditions that can lead to weight gain, but 95% of the time it is behavioral. Once your body readjusts its hormone levels and adjusts to the surgery, it is the dietary and lifestyle change that you have made that keep the weight off. If you return to your old habits, you will regain the weight. Again, stay focused. Follow our instructions carefully after surgery, attend the support groups, and make exercise a daily routine. If you find your weight increasing, please make an appointment. Don't wait until you have gained it all back. You will be provided with this instruction sheet. Please take it home and read it carefully. For now, I want to point out a few important details. Number 1. Beginning 1 week before surgery, do not take any aspirin, vitamin E, herbal medications, or NSAIDs like Motrin, Aleve, or ibuprofen. These medications can increase your risk of bleeding from surgery. Tylenol or Tylenol arthritis are safe. Number 6. Beginning 2 weeks before surgery, please start the pre-operative diet. This diet is designed to provide approximately 1,200 calories per day of balanced nutrition. This diet will help shrink your liver and make surgery safer. It will also introduce you to what the typical postoperative diet is like. Number 8. On the morning of the day before surgery, begin a clear liquid diet. Instructions for this are in another packet you will get. Also, you will need to drink a full 10 to 12 ounce bottle of magnesium citrate. This is a fairly strong laxative and will usually work within 2 to 8 hours. I recommend that you take this in the afternoon or early evening before surgery. This is available over the counter or in our office. Number 12. If you use a CPAP machine, please bring it with you to the hospital. You will use it following the surgery. If you don't bring it, your surgery may be canceled. Finally, you will be provided with 2 more packets of instructions. First is our guide for vitamin and mineral supplementation. This explains about some of the common vitamin and mineral issues after surgery and also gives detailed instructions on what you will need to take after surgery. For your convenience, vitamin and mineral supplements are available in our clinic or through our website. Second is our general packet for preparing for surgery. It gives you an overview of the nutritional goals after surgery and how your diet will progress. It discusses a few goals to practice now for success after surgery. It gives an example of the clear liquid diet for the day before surgery. And finally, it gives you a more detailed look at the liquid diet you will be on for the next 3 weeks.
Thank you for taking the time to watch this video. I look forward to seeing you in the office so that I can answer all of your questions and sign the consent forms. Once again, congratulations on taking this important step towards managing your weight. And thank you for trusting Anchorage Bariatrics to help you on your weight loss journey.